Hi, my name is Michael Karsy. I'm an assistant professor of neurosurgery at the University of Utah. I'd like to talk to you about our study using augmented reality to evaluate ventricular targeting using phantom and cadaveric models. This is a study we did in conjunction with Novorad, based out of Salt Lake City, and the University of Utah. So what is augmented reality? Well, virtual reality and augmented reality are two words that are commonly thrown around. And virtual reality essentially means a completely simulated environment. So usually a user wears a goggle and the complete environment around them is simulated and they can interact with it. Augmented reality involves images that are projected onto one's vision. And you can essentially interact with these images in many ways, in a way that you can use these digital images to then interact in the real world.
Show image. As we walk around, you can get a better view. We know that the tumor is on the left side. It's showing up on the left side. And it's almost like having x-ray vision, where you're basically looking through the brain and looking through the patient to be able to see exactly where the lesion is. So the superiormost aspect of the tumor is here. Drag, slice. Now I'm at the inferiormost aspect of the tumor. What we're going to want to do is make our craniotomy about 1 centimeter wider than what the border of the tumor is, and we'll plant our incision behind her hairline here.
And augmented reality, I think, has tremendous applications for medical imaging. So what are some of the things that we can do with it? We can use it for pre-surgical planning. We can basically plan out craniotomies, plan out incisions, then deploy them into a surgical environment.
We are going to go to the visor planning system and plan the landmarks we need to register the system, as well as any landmarks that we're going to use to identify the tumor. These points can be used to register an image. You can essentially affix the hologram to a fixed frame once you use these points to merge.
We can use it for patient teaching, where we display tumors, display patients' anatomy so they can better understand their own pathologies. We can map multiple images together. CT and CTA, MRI, tractography can be interlaid on top of a surgeon's vision to help with surgical treatment. And we can use it for anatomical education. Many times when we're teaching residents and fellows, and it's difficult to show three-dimensional anatomy, you can use this as a way of really honing in on 3D anatomy for a patient and helping a resident to understand how a surgery is being planned. Augmented reality also has tremendous application for intraoperative use. We can use it for planning and surgical treatment, again, taking craniotomies planned preoperatively and deploying them in a surgery environment. We can use it to identify 3D anatomy and better understand how patients' anatomy maps onto their head or any other part of the body for that matter. We can add video streaming and picture capture so you can teach other surgeons or show other trainees different nuances of surgical treatment. This is a case example of a patient who had a left frontal meningioma, which was segmented and then mapped onto their head. And you can see using augmented reality a way that that tumor can be localized and then intraoperatively again checked. And this image can be turned on and off as needed to be able to do the surgery. This is another case example of a stereotactic biopsy, which was done using augmented reality to plan the trajectory to the target site. Augmented reality can also be used for instrument tracking. So this is a way that instruments can be navigated down to targets and can be used for various applications. This is a study that we did previously looking at augmented reality to target pedicle screws, and showed that in 124 pedicle screws and 7 cadavers, open, including minimally invasive techniques, that there was over 90% accuracy in getting down to target. This is a systematic review looking at what has augmented reality been studied for in the neurosurgical space. And it reviewed 113 articles from 2010 through about 2020 and showed that most applications have looked at cranial surgery followed by spine and education. So still much more to do and many more applications can be looked at for this. And we're just at the tip of the iceberg right now with what augmented reality can do. We partnered at the University of Utah with Novorad, which is based out in Utah, and they are a wonderful company that has significant PACS and radiology experience, and now has developed an augmented reality system called Visor. This is a software that allows you to map on any kind of patient DICOM image onto an augmented reality system. In this case, this is using the Microsoft HoloLens 2. And so you can load any image, any hologram you want onto this. But the beauty and the advantage of the VISAR system is that it can recognize these APRIL tags, either placed preoperatively or intraoperatively, to allow mapping of holograms to a patient's anatomy with millimeter accuracy. You can map three-dimensional anatomy, you can map two-dimensional anatomy, any kind of DICOM will work for this. Other advantages of the NovaRad system is that it's 510 clear for preoperative planning as well as intraoperative use. This means this is a real system you can use clinically, not just a research tool. It's a portable system with limited footprint. The headset is really the only footprint that you need. The rest of the system works in a cloud-based format, so you can download images quickly. This could be used in a critical care setting, an emergency setting. It could potentially be used in the field. If you have images, CT images in the field. The capital cost for this is quite low, $4,000 for a headset and about $750 a case. This is much, much less than our other traditional navigation and robotics systems. And so this is an exciting technology to be able to study at our institution. There are various surgical workflows that you can use. Here's an example of skin and bone APRIL tags, basically these fiducials that could be recognized by CT scanner, then also seen by the VISAR camera and used to register a DICOM image to a hologram directly to a patient, or in our cases, a cadaver or phantom. You can basically place these tags and then obtain a CT scan, do your surgical planning, and then automatically register the hologram and begin surgical guidance. You can also use preoperative CT scans or MRI scans, perform your surgical planning, and then use a point-to-point registration system, which uses a calibrated instrument to then register a hologram directly to a patient. So in this sort of workflow, you either have your images ahead of time or you can acquire them in the OR, and either way you can use it to begin augmented reality-based surgical treatment. We sought to ask the question, what's the accuracy of augmented reality for placement of external ventricular drains, especially with this system that very, very much can be used in a clinical way. So we sought to explore the system using three different modalities. We first use a phantom model and use 0.5 millimeter targets and perform CT measurements before and after needles were placed into these phantoms. And this provided the best accuracy with how well the system used. We then use an Axiom system. This is a navigation system using EM technology, and it allowed targeting of 1 millimeter size targets, but it allowed reproducibility, so we could very quickly do many, many trials of targeting, which will show you some of the results of that data. And then lastly, we use a cadaver model. This, we compare traditional anatomical targeting using surface landmarks at Coker's point. For all of these models, we were targeting the lateral frontal ventricle as well as the occipital ventricle, two common trajectories that are used for EVD placements. And then we compared the accuracy of augmented reality for all those. So with our first phantom model, using CT to CT measurement of 0.5 millimeter targets, we showed a mean error of 1.2 millimeters from our needle tip to our desired target, and a mean angular error of 1.25 degrees. So these are exceptional values that we can get, showing that the true accuracy of the system is on order of approximately a millimeter, which is incredible. And then we looked at, well, how accurate is this using Axiom and reproducible? We found that with Axiom, you had a mean error of approximately 3.9 millimeters and angular error of 3.95 degrees. This is using the root mean square calculation as detailed in our study. And we looked at the differences in accuracy and noted that the Axiom system has its own internal inaccuracy that you essentially have to add to the system. But overall, this was pretty reproducible for how accurate the system is. And we could use the Axiom system to do a lot of other types of analysis. So one thing that we did was looked at different levels of PGY residents, all the way from medical students through fellows. Here is an example of two of our residents placing EVDs, simulated EVDs, for the first time using augmented reality. And the data essentially showed that there is no significant difference between different levels of students or residents when using the Axiom system. So essentially, the medical student shown as PGY0 was getting a level of accuracy statistically equivalent to fellows, at least for EVDs, which is kind of interesting. We also looked at whether experience with augmented reality video games or the specific side or the site of the EVD had a role, and that showed no difference in any of these factors for affecting accuracy with EVD placement using augmented reality. We also looked at whether subsequent trials of augmented reality help with accuracy, and instead found that right from the first time a participant used AR, they were achieving very good accuracy. And there was a trend towards some improvements, but really this was not significant. So we found that accuracy remained pretty stable all the way through multiple trials for each participant.
Next needle. So that's lined up from my view.
That's lined up there, so you want to kind of tilt your hand back. More, keep going. And that looks pretty good from this angle.
Okay.
Picking a second angle here. Move your trajectory, your entry point a little bit more lateral, just a couple millimeters, just a little bit more. That's pretty good, man. Yeah, it looks great.
All right. Feels pretty good. I mean, it's remarkable to get feedback from different angles. With this, you have an objective, non-moving target that they can give you feedback on. That looks pretty good.
Then using our cadaver model, we basically found that the overall accuracy for a cadaver model is about 1 centimeter when using traditional anatomical landmarks. But with our AR-guided system, we were able to get down to about 3 millimeters accuracy. So you had a 7.4 millimeter average improvement in accuracy with using augmented reality for the same target. And the angular error also showed the same improvement. And this didn't matter with whether it was left or right, frontal or occipital ventricle. So for ventricles that are very large, perhaps you could hit them when you're 1 centimeter off. But for small ventricles or a trauma setting where there's been shift, augmented reality adds that extra error of security that could be very useful in some situations. There are some uncommon EVD trajectories that aren't used very often. Coker is typically the most common point used. The reasons for that is that many of these other trajectories are difficult to use. They have unorthodox starting positions and angles and can be very challenging sometimes to employ. But using augmented reality, we sort of explored the other trajectories and showed that you could very easily get down to the ventricle, simply because you can just see where the ventricle is from the starting point that you've created. So it can be immensely helpful in maybe some of these unique situations. In conclusion, we found that augmented reality had an error of about 1.2 millimeters when measured by CT scan and 3.9 millimeters when measured by Axiom. The accuracy did not depend on PGY level, augmented reality experience, EVD placement experience, location, or number of trials. And we showed that when compared to traditional anatomical Coker's point targeting, augmented reality improved accuracy by about 7.8 millimeters. Here's some other areas of development using augmented reality for trigeminal neuralgia treatment, potential targeting of foramen and volley, as well as use of augmented reality for identifying skull base anatomy, specific craniofacial anatomy, using it to dissect bone and be able to see the skull base. So various other applications for AR that makes one really think about what this technology could be used for. We'd like to thank the Department of Neurosurgery at the University of Utah for their wonderful support of this program, as well as our partners at Novorad that really helped make this idea become a reality. Thank you very much for your attention.